mention the COVID response team.
Okay. Hello, I'm David Scharff. I'm co-chair of the COVID-19 Advisory Committee of the American Psychoanalytic Association, along with Todd Essig. And it is our pleasure to present to you a series of talks and discussions on getting online in this time of COVID-19 pandemic. We will begin with a talk this morning by Dr. Jill Scharff, and this is a recording of the talk that she gave as the opening talk when it was not recorded due to an administrative glitch. So this is a recording in which Jill will be talking using her PowerPoint slides as well and responding to questions that were generated in the original talk, which I will give to her from time to time. But I'll introduce the whole series right now. So I'm a member of the International Psychotherapy Institute, whose analytic program is a member of APsaA. Jill Scharff is the co-founder of the International Psychotherapy Institute and founder of its analytic program. And she has edited 4 volumes of Psychoanalysis Online published by Carnac and Routledge, as well as articles in the International Journal and the Journal of the American Psychoanalytic on online psychoanalysis. The other members of our presentation, which is a series of 4 presentations, are Ralph Fishkin, who is co-president of the Philadelphia Psychoanalytic Center, former secretary of APsaA, and has many years in several publications of online psychoanalytic teaching and therapy in China. And Ralph will be giving the second of these presentations. About 3/4 of that presentation was recorded, and that will be the second of the presentations in this series that now will be posted online. Sharon Blum was the original author of the seminal articles on telephone therapy before online video therapy, and she has years of experience in distance psychoanalysis. She's a faculty member of the New Center for Psychoanalysis in Los Angeles. Lena Ehrlich is a training analyst and a member of the Michigan Psychoanalytic Center and has written extensively on psychoanalytic practice, training, and distance analysis, and she will be part of the final presentation together with me. Jeff Taxman is chair of APsaA's Committee on Community Psychoanalysis, is a member of the Wisconsin Psychoanalytic Society, and Jeff has 25 years of experience in interventions in mass crises and trauma. And his presentation will feature the overall view of the pandemic and its results and mental health implications of what we can expect to be coming as this unfolds. So having introduced all of the panelists, it is my pleasure to turn this over to Jill Scharff to talk about going online in this time of COVID-19. Jill.
Thank you for that introduction, David. We're going to begin by thinking about the demands of COVID-19 upon us, and they are considerable. I've been talking to therapists and analysts from around the country and indeed around the world, and they're all saying that the physical distance imposed in order to flatten the curve of the epidemics in the various countries, that physical distance is imposing a social isolation that people find extremely challenging. They're no longer able to meet in physical co-presence with their friends, even family members who live at a distance, and of course, their patients. The incredible thing about this pandemic is that the sort of stressors that patients are coming to describe to us are the very same stressors that we ourselves are feeling. I'm talking about the fear of contamination, being terrified that you'll catch this virus from some surface that you cannot tell whether it's there or not. So we find ourselves running around cleaning our doorknobs with Clorox wipes or disinfecting surfaces. a necessary precaution, but one that is preoccupying and emphasizes the fear that we're all living with. There are major worries. Patients will speak of their fears of loss of income. And as you know, 6 million at this point, I think, in America are now unemployed. That you know that some of those people have families, they're worried about food. Some are worried about losing their houses and landing up on the street. Therapists too can worry about loss of income because those patients are no longer able to pay for treatment, and they may need a much reduced fee. Other patients will be able to accept a move from the trusted office where they meet the therapist to a virtual space if that therapist offers teletherapy. At the same time, however, it's not so easy for the patient to create a private space from which to enter this virtual space in which to meet the therapist. Patients are at home now, they're teleworking. Many of them have children. Their children too are at home because the schools have closed. I mean, colleges, as well as high schools, middle schools, elementary schools. The only thing that's still open are the daycare centers for the tiny tots. And many parents are dependent on those centers, but terrified that their children will be infected going there. There's no easy answer, and people are under immense strain trying to develop new and creative solutions to the current situations. As time goes on, we see more and more news of illness, hospitalization, people on ventilators, and people dying. We face the loss of our loved ones. I mean, you're in denial if you don't face that fact. And we have to help our patients come to terms with it and be able to verbalize the fears that are all around us. It's not easy when we face the same fears, when many of us are in the age category where we could be denied a ventilator if it came to that very painful choice for the health professionals in the intensive care units. At a time like this, we look for leadership. We look for a coherent message from the government and the professional medical associations, psychology associations, social work and counseling. The professional associations were pretty quick to say, stop seeing patients in your office and move to teletherapy. It was a very clear and sudden message, which was, I think, somewhat in advance of messages we were getting from the government, where it seemed to be that, yeah, you should sort of stay at home and be careful, but there was no clear directive. We have that clear directive, you gotta move to teletherapy. Now, some of us have been doing that, and I've been doing it for 25 years, not because I ever wanted to, but because I had to, in order to offer psychoanalytic training to people who lived outside of a major psychoanalytic center. I'm talking about colleagues in the Republic of Panama who were eager to have training. And we knew these people very well from years of experiencing them as students, and felt able to offer a combination of what you call shuttle analysis. In other words, they studied nearby and began their analyses in person and then moved to teletherapy in a very slow, considered, cautious way with lots of community support for the effort. That's not what's happening now. People are suddenly having to do something that they would prefer not to do in some cases, or have never done before, or haven't thought of developing the skills to do this. And all of this huge learning curve is being forced upon therapists at the very time that they're dealing with major stress. People are having to move from their office where they feel secure and have everything around them to enable them to provide the kind of containment that is necessary for our kind of intimate work, and suddenly make up some kind of a space at home from which they can work. We'll talk later about how people are managing to do that. Lastly, we know that even though we're maybe arriving at what they call the peak of the virus in some parts of the country, of course, another problem is the country's at all different stages of this. Even when the peak is reached, after that, there will be a continuing awareness of damage, loss, and change. At this moment, we can't know what life is going to be like after COVID. We only know that it is going to be profoundly changed from what we know of it today. So people now are living in conditions of a shelter in place, and we want to provide continuity of care for patients, or at least for those who choose to work together under the new technology-mediated conditions. We've gone from a place where teletherapy was an, excuse me, an option, maybe something rather distrusted by some people, looked upon as controversial at least, and now it's a recommendation. And the rules that we had before are temporarily waived so that we can make this adaptation, not only to the needs of the technology generation and the adaptation of the global economy of the 21st century, or simply just to respond to a pandemic. Now, there are times when, even though you might want to, you really shouldn't make this offer of teletherapy. Or at least you should consider it very carefully in each case. You cannot do it if it's illegal. You cannot do it if the country or the state objects to your doing it from your own state. You especially cannot do it if the patient is a person of interest to the government. That makes it unsafe. I mean, we all know that technology is vulnerable to hacking attacks. And even though you are supremely careful with your security settings, you know that anything can be hacked at any time, and it's a major worry for us. At the same time, the kind of things our patients talk about, which are highly personal and intimate, possibly filled with guilt or shame, actually are not things that are of interest to any kind of spy networks. It's difficult to do this work if you have a patient with uncorrected deafness in analysis. That person will have trouble lying on a couch, but would do in your office anyway. There, a face-to-face communication could even be advantageous because they could read your lips. But you would then face the difficulties of a face-to-face interaction if that is not what you're used to. We can talk more about the differences of face-to-face interaction in the office versus on the screen. If your patient has a diagnosis such as paranoid psychosis, borderline personality disorder, psychopathy, addiction, uncontrolled addiction, not in remission, or is actively suicidal, then these are contraindications. But that said, there may be patients with those diagnoses who have such a strong treatment alliance that you can dare to offer a teletherapy. provided that you have support for it, that you have telephone contact information, address, a responsible person, a family member that you can contact in case of emergency, a local psychiatrist who will support your treatment, respond to emergencies as needed, or will be able to take over your care. If we're talking about a patient who has fled New York, let's say, to go to a country residence instead, and should really do better with a local therapist.
Jill, I wonder if we might have a couple of questions at this point. They go back, I was thinking of going back to your original point about the resistance to moving to therapy, which has been, in some cases, institutional. But Paula Durlovsky asked the question whether we could examine the resistance to switching to virtual therapy and suggest ways to work through it.
Well, there, Paula is asking, I think, about the patient's resistance. We also need to think about the therapist or analyst's resistance. The first place we have to start is with the analyst or therapist. People who are used to working in the office, they really value the setting and they value physical co-presence. They really rely on it as an information system to them, and also as a support to them in just relaxing, in being open to free association. And it's very understandable that when suddenly confronted with having to gear up a technology in some kind of a makeshift office at home and see their patients on screen, that it feels very, very different. And it is very different. There's a lot to get used to. The image of the patient is a flat one. It's 2D. There are no smells. You don't see the whole person moving around as usual. You see this image of the person. Very, very different. And some patients, of course, choose a phone. They choose not to move into a video technology situation. That analyst or therapist also is surrounded in the community by a lot of literature, some of it for, some of it against, very often overly impassioned in either direction. Finds it difficult to know how to evaluate the whole situation, and looks for best guidelines, best practice guidelines, actually can now find them. That wasn't true before. One thing about COVID is it's really brought forth good practice guidelines right there on the APsaA website, right there on the APsaA website. There's a lot of help. But still, these people have had to suddenly move to teletherapy with really hardly any time to talk to their patients about it. Yeah, they may have been saying, I don't know if we'll be able to meet in the office by next week. So there's a little warning, but really suddenly it came to us very fast. You've got to change. So they didn't have time to work on their patient's resistance. And I think this is why some people have lost patients who didn't feel able to make that switch. Others, and usually it's patients that you've been seeing for quite a long time, more than a year. Those patients have developed enough of an internal connection to you that they can overcome the obstacles of the external frame. We're going to talk much more about the importance of the external frame, but people who've made the switch, they didn't really fully know all this before they had to make the switch.
Well, Kristen Gross about patients' hesitation to continue or to want to cut down on session frequency, or bringing in questions about reductions in income.
Yeah. Well, I think therapists and analysts are very used to evaluating financial need. And have generously, slid down their fees to accommodate. Of course, it does raise the analyst or therapist's anxiety as to whether their income will be sustained. One thing that teletherapy offers is an opportunity to maintain income if the patient can afford it. Income that would be lost if the office were simply closed for 3 months. Reduction in sessions, that's another thing that's requested. That seriously limits the effectiveness of the treatment when that happens. Most people are finding that their patients are talking a lot about the strains of COVID and that previous themes of the treatment have been put on hold. I imagine that may settle a little bit, perhaps not, we'll see. It's what's on everybody's mind. And of course, every trauma such as this channels back to earlier traumas. People remembering when they were kids, locked up in hospital for a week with scarlet fever, or in an oxygen tent because of asthma. Maybe they think back to Ebola or Zika virus and recall those earlier traumas in the light of the current trauma. Some patients who are health professionals, I've noticed that sometimes they skip sessions because they're so busy. Sometimes they attend sessions but feel terribly guilty for taking time away from their essential duty. And others feel very scared of coming in and infecting the therapist. And I mean infecting the therapist not with actual virus and contaminating surfaces, but with their pain and the awful things that they have seen and done and decisions they've had to take. Worry about burdening their treatment professional. Of course, we are trained to cope with that, to absorb and contain a great deal of pain and anxiety. And the same is offered across a technology-mediated situation. I'd like to talk a little bit about problems that therapists had doing this before COVID. I mean, they were terribly worried about being criticized by colleagues for doing something that was, quote, breaking the frame. And the lack of guidelines, it meant you were having to invent it as you went along. Very helpful there if you have a group of colleagues to consult with. That's really a protection against feeling terribly lost or afraid or criticized, out on the edge. The states require a therapist to be licensed in your own state and in the state where your patient resides. And so therapists who are treating people who have to suddenly travel for work to various states from time to time, they face either interrupting the care of that patient or offering telephone sessions, let's say, which are not, strictly speaking, covered by the law. And that's a big, big risk that those therapists take. Nowadays, the Office of Consumer Rights has waived many of those requirements. It's always best to check with your own state and your own discipline and the patient's insurance company if this is indeed an unrestricted area for practice at this time. That takes us on to the ethical stance, which is you must investigate. You must know the regulations for your discipline, your state, and your patient's state. If that state is not local, of course, which during the pandemic, mostly it's local, except there are patients who are decamping to the beach or to their mountain place somewhere else. You have to be careful there normally, but in this environment, the rules have been relaxed. You always evaluate the indications, assess the patient carefully. And usually you would be looking at local options. Now there are no local options. It's you or nobody, basically. You still acknowledge with your patients that it is still somewhat experimental, although it's now widespread. And make sure you get informed consent. I mean, you know, the horse has bolted and the barn door is closed now. I'm a little late saying these things, but it's important to know. Of course, you maintain professional boundaries as you would in the office. The session starts and stops on time on an agreed schedule, and you maintain the level of abstinence needed for the emergence of unconscious communication analytic process. The transference may shift a little because you do have to do some education to help the patient figure out how to set up a setting that will be adequate for the work. You do need to discuss these matters of informed consent. You need to say hello at the start of the sessions. And can you hear me? Can you see me? Are we connected? Fine, then the session can begin. It is a different entry into the treatment space than you're used to in the office. These adjustments have to be made, but it doesn't mean that you then carry on acting in a friendly manner. You act in your usual professional attitude. And you deal with the reactions that you're having to the new setting and the patient's reactions. And you may be dealing with strange things. The patient may have a limited ability to set up a private space so that the door may open, a cat may come in. The door may open, a child may enter. That's where pre-education is so useful. You can work with your patient to anticipate these events, but there hasn't been time to do that in this circumstance. But the main thing is seek consultation. Ask your friends, have peer groups. APsaA is rolling out a program of peer consultation groups where people can discuss their work challenges in this very peculiar time. And I think people are going to find that very helpful. And then there are courses. You can look for courses online. APsaA is doing these free courses. There are resources on the APsaA website and at the APA website. Just use everything and we just try to help one another get through this. We're all in it together. Patients, therapists, analysts, everybody is suffering. Everybody needs help. Everybody is looking for connection. And that's what we're all trying to find gathered here today.
And Jill, I'd just add that the APsaA discussion group, peer support groups, are open to everybody, not just APsaA members, and open equally to psychotherapists, to analytic psychotherapists.
To anyone all over the world, isn't it? It's anyone who can...
Anyone in our field.
Access it.
Working
any health professional. Yeah. It's, I mean, that's what it's all about, really. We, as a community, we all have to come together. In fact, the whole world has to come together, which is really the main positive thing about this COVID-19 novel virus situation. David, I think I'd like to turn to some PowerPoint now.
Okay.
To help me just put up the nuts and bolts. I think that the next time we meet, Ralph will be talking rather more about the internal frame. And today I'm to focus on the external frame. Pick up at slide 9, please, on the external frame, where we're talking about the office setup for teletherapy.
Okay, here we are.
Let's say you're the therapist, you're the analyst, suddenly you have to communicate with your patients from home. You need to set up a secure space at home that you can call your office with a door that closes. You may be in a cupboard, the closet under the stair. That is fine. The patient is not going to see the boxes at your feet. If you can have a more comfortable place, obviously it's better. But the prime consideration is no noise, no interruptions, and preferably not a distracting background. Now, if you look at my background, it does not meet the ideal at all. It's my office. It's the actual place where I see patients. You may see the couch, and on the other wall, you may see books and toys and things, because I see children here too. But I keep it this way because this is where my patients normally see me. My office is at home. But for those of you who are creating an office, if you can choose a very neutral space, something that doesn't reveal too much of your own home life, it's going to be better. You want to make sure your internet is adequate, password protected, has to have enough bandwidth. And you might, you might want to consider the fact that other people in your house may be sharing that bandwidth, and not that it will leak over from one device to another, but it may weaken the signal. You may need to move closer to your
router.
Yeah, I'm looking for mine. It's someone's moved it. Yeah, it's right there. You need a good headset and web camera. Well, you need probably the one in your computer will be quite adequate. But if you want improved vision and sound, you buy a web camera and you use a headset. Now you'll notice I am not using a headset, and neither is David. We're kind of broadcasting here. And I have a very good microphone. I can show it to you, I think. Can you see it, David? I can't see anything because I'm looking at PowerPoint. Yeah?
That's
really well. It swivels.
Snowball microphone.
Yeah, but there are lots that you can get if you go to the internet and look for it. I recommend a swivel chair. You know, people tell me they get so tired doing the teletherapy and they end up with sore muscles here and sore eyes. So I have a swivel chair, and it means that I can look at the patient from here, I can look at the patient from here, and I can look straight on. And that gives me more mobility. I think you'll find that really helpful. You need good lighting in front of you and shade the windows. You'll see behind me, I've completely shaded the long windows, and I've shaded the one near me. Then you can see a little bit of greenery out the other windows. I mean, that's a loss to me. And in between patients, I certainly take the time to look and enjoy the outside. I walk outside, I get some fresh air and come back in. We all know this. It has to be the same place, the same setting, a consistent office setting. Next slide, please, David. So setting up your technology platform, I assume you have now done this. And you can use your desktop, laptop, or iPad. And you need proper technology. I know it has been said by the Office of Consumer Rights that you can use an inferior platform right now. They will not sanction you for using Skype or FaceTime, but those are not recommended under normal practices. And seriously, you're better to do the thing the proper way. This means downloading a HIPAA compliant technology, such as Zoom, VC, Doxy. These are business platforms. And they come with good encryption, good security, and the protection of a business associate agreement that they sign and that you sign. You'll hear this referred to, the BAA. What's the BAA? It's this agreement that is what makes the technology HIPAA compliant. And without it, you are not HIPAA compliant. It gives you an added degree of confidence in the professionalism of the teletherapy service that you're offering. You want to update your antivirus, malware stuff. and take the tutorials. The VTC companies offer terrific tutorials. They show you the progression of the screens and everything.
Video, VTC meaning video technology companies.
Yes, such as Zoom. You go to zoom.us. I say Zoom because that's the one I use. It's not an advertisement for Zoom. VC is also good, and so is Doxy. I'm sure there are others that I don't know, but you can investigate them and practice with a colleague before you start working with your patients. It's too late for this news now, but there it is. Next slide. In preparing the patient, you're best to discuss how you're going to send the bill, how you're going to charge for them if they have to miss a session if they're late, how you're going to accept payment, how you will bill and code it. I mean, if this is a Medicare patient, you have to know how to add the 95 tele code at the end of your normal procedure code. You normally check into licensure, you get informed consent. Some associations, particularly American Psychological Association, advises a written informed consent, and they have a template for one that you can find on that site. As an analyst, I've always preferred to have a verbal contract with my patients, and that is the same for the teletherapy. So you have all established an in-office relationship. It has to be said, though, that there will be people under the strain of this virus who have not been in mental health treatment, who suddenly are going to need it. And it has already started, requests for treatment to begin online. And there are some people who've had experience with that. I never have. I think it's tricky, but it is approved right now and it can be done. So once all this is done, you're going to meet. You have to think of yourself meeting in transitional space. It is co-created by the patient and the therapist analyst. It's new. It's a new space to be in, and it calls forth a lot of new learning, creative adjustment, and some amazing opportunities that I'll tell you about in a minute. Next slide, please. So yeah, you do make this assessment of the cognitive and emotional competence. Check up the family support. Is this person able to use the computer at all? Will they be able to have a private space? Will their family support it? If they live in a roommate situation, will the roommates support this? And understand it's different, but it is effective. Next slide. An equally important part of the frame, and this you know already, is the frequency, the duration of the session, the routine. An unusual part is that the patient is responsible for his or her part of the setting. And this is new. It puts you in very new territory. Sometimes you'll face anxiety, feeling that you're intruding into this person's home situation, which you have never been in. Sometimes you may feel envious at what you see. You might have to deal with some pain, surprise when odd things happen. So just as well to be prepared for that. It takes away from you that control that you have had over your environment. Some patients have said it makes them feel more equal. It has reduced the idealization of the analyst. Well, I haven't heard that, but then again, I guess I haven't felt so much idealized. I think that it has to be the provider who initiates the invitation. You send out an invitation on Zoom that specifies a time, a place, a room number, and a password to enter that room. After that, it is routine, and the patient will initiate the call. I always open my room maybe 5 minutes before the time of the appointment, and the patient will be waiting there in the waiting room, and then I admit them. Once they're in the room, I lock the room. And that's an important thing, so you don't get intrusions. You've probably heard about this Zoom bombing thing that's been happening, but that's happening to huge meetings. I haven't heard that happening in therapy sessions, which are not of great visual impact for a Zoom bombing hacker.
I think, Jill, Zoom has now increased the level of security, partly in response to that, by most new room numbers now require that the patient have a password, which you give them to get in. So that is the first level of security. And the second is this locking the room, which maybe you can tell people how to do that.
Why don't you do that, since you're looking?
Locking the room, you go to manage participants, and you click on that. It brings up another box, and under the word more comes down another drop-down menu, which includes locking the room. It then says, are you sure you don't want anybody else to be able to join? You click yes, and then that locks the meeting against intrusion.
When we've been teaching this series, we've not been locking the room, because people sometimes get thrown off the internet at their location. They have to check in, come back in. So those have not been locked. But with treatment, one always locks the room. If the patient gets thrown off, then the patient will alert you to the fact that they need to come back in, but they have the password so they can get in.
Well, they can get back in even if it's locked. It's not locked against them.
Exactly. So, next slide.
Next slide.
Yes, please. We've got to prepare for contingencies because they happen. Interruptions in the internet connection, that happens. This is why you give the patient your phone number, so there's a separate channel through which they can reach you. And you write it down so you have it. You give them your number, ask them to write it down so they have it. Then if there's a problem, they can call you and you can together negotiate on the phone how to fix the problem. You may decide if the sound is bad. Sometimes you get a good enough connection, but there are dropped syllables. You can improve that sound by closing the video. You know, you've seen the patient seen you. Now you can work with the auditory channel only. Or you can keep the visual channel, turn the sound off, and have the patient connect to you through their iPhone so that you get the audio that way. You can mute your own audio to offset feedback. Obviously, you have to remember to turn it back on when you are ready to make an interpretation. Yeah, you learn the patient's local resources, family support, whether they have maybe a social community, a religious community, a local psychiatrist, family doctor. Next slide, please. Now, some people already use Zoom. They know how to do it. You don't have to instruct. It's so weird for an analyst to have to be instructing anybody in anything. But these are different times, and it's just a way of creating a firm external frame. And we all know that that frame is essential to being able to support the work we do with our internal frame. So we prepare the patient to log in and use Zoom if necessary. Some people do not want to do it. Fine, you can use the phone. The phone is not a second best alternative. It is an alternative. There are some analysts who much prefer the phone and some patients who prefer it. They will say that they hear that sound coming direct into their ears, and they find it to be a very intense and intimate connection with the patient. Without vision, which is also a distraction, even though it gives a lot of information, other channels compensate. The attention to the quality of sound, the emotional content of a silence, the anxiety that is stirred when there's a hesitation in the breath, or a catch that indicates a tear that you can't see, but you can tell there are tears coming. That sensitivity is much increased when using the phone. There are patients who prefer the phone so they won't be seen. And this may be a way of avoiding the discussion of a shame dynamic. Yes, David?
Well, there are a couple of questions that seem relevant to things you've been talking about. One is David Small, who made the comment that I found it eye-opening where my clients put their cameras. Some are more open than others, but they're certainly letting you into their homes for the first time. And then the question from Andrew Dulcimer, how do you teach your patient where to put their camera?
Well, I say it's okay if they just use a camera that's inherent in their equipment. If it's good enough, that's fine. If you want extra special camera, then you clip it to the top of your computer. I can't show you mine, or they'll all be lost. But yeah, it just clips on the top. I have to say, as to how much access you get to the room, it really depends on how close you sit. Look, if I sit much closer, you'll see less of my room. If I sit way back here, you'll see more of it. Now, when I'm working with children, the child will very often be using a cell phone, and they take you with them, literally carry you with them right through the house till they get to their room, because a parent has to help them get started. Then they go to their private room, and then they'll show you all their toys and all their paintings, and you get a very complete view of their room, because they're very proud of their rooms, very identified with them, and it's actually quite fun. I would not feel comfortable doing that with an adult patient, I have to say. With the adult, I just want to see them in the space they have chosen to meet me.
Jill, maybe just for a second, because you've segued into child therapy, which I know is not your main.
No, I'm not going there.
Well, there were questions, so that I thought maybe briefly you could go there. Marian Margley said that she works with children and has on teletherapy, and has found it instructive as she and her child patients find ways to talk and play together, and about how it's different. And they tap into their creativity in remarkable ways.
Oh, they do.
Grace Kim wrote that Zoom has great tools, such as the whiteboard feature. Being prepared with lots of activities and using websites such as GoZen are what she's found to be useful. That whiteboard feature is one that is interactive. So the child therapist and patient can both draw on a whiteboard, which can then be saved.
Well, when we do we're doing a child course through APsaA starting April 16th, and we'll be showing the function of the whiteboard and how you can interact. But I don't want to do that today. I think it's a little off topic. But to go back to your earlier point, yes, the children are very creative, and they'll actually play with the technology. Of course, grown-ups play with it too. They don't call it playing with it. They call it expressing their resistance through it. In other words, they'll hit the wrong key on the keyboard. They'll close down the screen. You won't see the video because they have forgotten to open the video. or they'll mute themselves so they're speaking and you can't hear what they're saying. There are all sorts of technological glitches which are patient-made. Actually, it could be therapist or analyst made from time to time if you're having a strong countertransference. Always beware that the technology is the place where the resistance, that transference, that countertransference is projected, because the technology is part of the frame. And we all know that the frame is a place where the transferences are expressed.
I'd like to also enter a question about privacy. Devashanka Gyend wrote, how does one make sure that the confidentiality and privacy is maintained? As for some clients, they have children or their parents around, and that can be very intrusive and even traumatizing. Or somebody may be in the room that you don't know about, listening in.
Well, that's the preparation. You have to make it clear. The space has to be private, or we can't do our work. And whoever is in the room has to be visible to the camera. That's true in couple therapy. You have to see both members of the couple. If it's a family, you have to see the family. Whether that means they're all in the same room or different family members are in different rooms. You know, you have to see everyone who has signed up for that session. And I keep thinking I'm forgetting one of your questions, because you asked two.
You've done pretty well.
All right. Okay.
Well, I mean, the whole issue of privacy for the patient in there.
I dealt with that earlier.
No, I know you did. And I think you also now have just segued a little bit into what if you see couples or families.
Yeah.
And that is possible. And it's possible to have a couple or family meeting in an analytic way as well.
Yes, it is. Confidentiality with children is a particular concern. You know, you have to evaluate if the parent can really do this. And, you know, an intrusive parent is not going to do it properly. And if you feel that's going on, you can take care by the way you phrase things to the child. Like, you get the child with a Bluetooth, so they hear you through their headset. The parent cannot hear what you are saying. And if you feel the child is not able to speak to you, you can ask them to show you with the toys. And you can also guess and say, let's play a guess game. I say this, you say yes or no. Thus, if you know the parent is listening, then you know that the child is protected because they're only saying yes or no. I mean, it's far from ideal, but you know, you do have to be somewhat inventive in this situation.
Put back to your PowerPoint.
Right. Well, you were talking about the private space. You remember to turn off all your apps. Mine is off. Turn off your notifications on the computer or smartphone. I just got a new system here and I don't yet know how to do that. I need to get those notifications removed. Safeguard privacy from family and roommates. Yeah, they've got to stay outside the place. Oh, no recording without permission. Of course not. So that's it for that. Let's have the next slide. Take care of you. Of course, we follow the CDC guidelines, but you change the height of your swivel chair. I mean, this chair will go up and down. So it changes, you see that? Changes the angle of my hips. And then if I want it to go back up, I just go back up. Rest my eyes. Yeah, I look out here as well. Sometimes I look down there, sometimes just below the camera, which is the place where you feel I'm speaking to you. If I look here, I'm looking at David in his little box on the screen. I think I'm speaking to him, but actually I'm not. It looks to you as if I'm not speaking to you. And he probably doesn't even think I'm speaking to him if I speak like that. Is that correct, David?
Right. It looks like you're studying something, which you are.
I have to look here. You can alter the brightness on your computer, so it should be at the right level for your particular eyes. And you need exercise. You need to breathe the fresh air and get a little sun if you can between every patient, I say. It's fun to use Zoom for non-professional purpose, not just, with your patients and your peers, although it's, it's nice to get support from peers. You want to visit with your friends and your family as well. Teach them how to use it, not just Skype, which is what most of them are doing, or FaceTime, which comes up on a little screen on a phone. Once you get them onto Zoom, they absolutely love it, because we can have a cocktail hour where one has a drink, the other has a drink. You have a drink together virtually and talk. Of course, what we're mostly talking about is this current situation. And then you can have active, you can take a ballet class that has been streamed from your local ballet studio, or you can just get together with your friends and their children and jump around the room to music, have a little dance party. Anything, think up anything and get through it together. Now we're going to start thinking more about the internal frame. In the first teletherapy session, you say, hello, you check in. Can you hear me? Yes. Speak into the microphone and ensure that nobody is muted. Look at the camera to maintain good eye contact. Turn off all the apps, all the notifications. Verify the patient's identity. If it's a new patient, which these days it might be, make sure it's private. Make sure you can see everybody who is currently in that space. And then relax. Then you just sit back. You don't have to lean into the thing like this, looking at everything. No, you just lean back. You let your eyes drift around as you do when you're in your own office. And you respond when you feel like it. You interpret as usual. And as I said earlier, you will find that if you notice every interruption, every distortion of the frame, because if you take it just as a technical issue to be corrected, that's one matter. But you also then want to look behind it as to what is the latent communication here. Is there fear of connecting? Is there anger at you for abandoning the patient by closing your office and having to move to this unknown teletherapy kind of thing? Can I show the next slide? I want to share a piece of theory that I have found extremely helpful. It has now been translated from Spanish. This is by Blecher, who has a theory that the frame holds the mother-infant symbiosis. I have found that in the office with some patients who have very early infantile trauma, the comfort of lying on my couch with me nearby, closely attentive, actually means that the early trauma is hidden. It takes a long time to get to the place where you are then experienced as the dead mother, when you're sitting there as a living, breathing, attentive, responsive analyst. And the move to technology can actually bring this out, take it out from hiding. And if you just look at how the patient relates to the frame, I mean, there'll be objections to it, there'll be hatred of it, there'll be attacks on this new frame. All of it highly informational. And without that, teletherapy will be sterile. then it will always feel second best, as opposed to something that is different, but of some value. There are people who say, look, this is all very well in the meantime. It's a placeholder. It's not real analysis. And some analysts who do consult people all over the world do so with some technical facility, but they have never done analysis that way because they would never break the frame in that manner. But the frame we come to work with as analysts is an internal frame, a frame that is focused on analytic process. Can analytic process occur in a teletherapy environment? Well, why not? It is a firm frame. It's a different frame, but it's a firm frame, and attention is given to the frame. Free association occurs. Dreams are mentioned and associated to. Children play. The unconscious communication happens. Transfers and countertransfers happen. You give interpretations. You are met with resistance, defensive reactions, transference, manifestations. And of course, you spend time working through. Now, you can't just take this from me. I have to give you examples. Let's take unconscious communication. How does it happen? Can I have the last slide again, please? This unconscious communication. I'm giving an example. Well, maybe we could put the slide away for a minute.
Yep.
So I'm working with a patient in analysis. It's maybe the third year of the analysis online, and she's been feeling depressed. She's been remembering how hard it was to be banished from her home to a relative's home. That, of course, is something that current patient children might face. Say the parents are emergency medical professionals. Those children might be sent to live with an aunt or grandparent during this epidemic so that they don't get contaminated. It could happen. Or the parents could be sent away, leaving the children with someone else at their own house. Anyway, so this woman was talking tearfully and remembering the place she was sent to live. And she said, yeah, she used to get so sad. She would go out and get a little fresh air on the balcony. And she'd look over and she'd see the paving on the patio and some little flowers there. And I suddenly had a physical feeling. It started about here of dropping. I just felt I had dropped. And I was so surprised by this, a very visceral situation. And then she said how often she had felt life was not worth living, how often she had felt like throwing herself over that balcony. Now, I'm giving this example because I had that physical feeling before she said the suicidal wish. So to me, that is evidence of an unconscious communication. I mean, I had a vision of looking over a balcony and seeing the stones below, and that happened in my body. Well, after she said that, I told her this had happened to me, and she said she felt that for the first time, someone had been with her in her distress. I don't want to make too much of it, but she did say it was a very important moment in her recovering from that early. Well, not so early. I mean, she was a little 8-year-old by then. But that was part of her recovery, conveyed through, psychoanalysis online without video. That was a telephone analysis back in those days. An example of transference. One analyst reported moving away from this area and retaining continuity of care with a patient that she obviously had left behind, and moving to a teletherapy format. And that patient had always been very agreeable and very agreeably accepted this analyst's move and very agreeably moved on to teletherapy, and it was all going very fine until at a certain point, the patient began failing to connect, having problems with the computer, children interrupting the sessions, all sorts of attack on the frame that were the beginning of the emergence of a massive negative transference, all conducted through the technology. Okay, so I think the next slide, there is one point in that next slide I'd like to make. Next one.
Yeah, let's say.
Which?
And Jill, I'll just tell you, we have about 20 minutes, so.
Yeah, we're fine. We're doing fine. Language triggers the creation of the image. On the phone, you hear the words, images form in your mind as part of your reverie, your free association. If you're using video technology, you see this flat image and people say, but it's not like having a real body there. Of course it's not. It's just an image. I call it a marker for the person. And you look beyond it. You experience the humanity, the shared humanity beyond that image. Otherwise, you'd think of the screen as a barrier between you and the patient on the other side. No, it's just a way of remembering who you're working with. And you connect then in a virtual realm that is much closer to what you actually do when you work in analysis with a patient who's in the room. They're lying on the couch, you're in your chair, and you're following your free associative thoughts as the patient does too. Next.
Would you say, Jill, also in a way, the screen is a kind of tangible transitional space where the two of you meet in an image?
Well, I definitely try not to think of it that way.
Okay.
Obviously, it is tangible, but.
Well, I'm just saying it's a marker for the
No, I think of it as a portal, not. That would be how I would think of it.
Okay.
And if I could have the next slide.
Not this one.
Right. Look, in order for teleanalysis to work, you have to admit it's not the same as traditional in the office analysis. It's not the same. If you mourn it, you can have it then. You can have it be something that is meaningful and fully effective. But there are people who complain. There can't possibly be unconscious process. I've tried to prove to you with a little example there can be, because mental representations form in your mind as the unconscious communication reaches you. It also forms in your body. You have somatic reactions. You can get a headache. You can get, one time a person had, he described a rash on his leg, on his ankle actually. And, you know, you normally think of a rash as pimples or whatever. And instead of thinking of a rash, I thought of something that looked like a graze, what you might call a carpet burn. This was someone who had been physically abused. And I said, I'm wondering about the rash. It's come across to me in my mind as kind of a graze. And I said, like a carpet burn. And the person said, oh my goodness, it's not a carpet burn. That's where the ropes were. And I was struggling against them. And with that realization, then the rash was going away after that. Okay, next slide. Here are the objections. There's no body present. Okay, now, this is true. You lose the possibility of fantasies becoming true. A patient who wants to murder you cannot do so. A patient who wants to have who has an erotic transference, wants to rape you in the office, cannot do so. Then there is some protection offered in a teletherapy setting, but it also, it can allow the patient to express more fully such aggressive or sexual fantasies than might be possible in the office. At the same time, it may be less stimulating of such fantasies, so they may be less accessible. So, you know, you just have to work with what your medium offers you. And with teleanalysis, you do have this increased sensitivity to the voice, to images that form in your mind, to your bodily reactions. And as Freud used to say, the body enters the conversation. Yes, it does, even when you're working in technology-mediated teleanalysis.
Jill, just I know you're going to switch topics a bit. And so there were comments about the loss of bodily co-presence in the room. What occurs to me is, of course, this has been cited as the main objection to using teleanalysis, that the bodies are not present in the same room. Heather Graff wrote, I sense a denial of what is lost when physical co-presence is gone. And I think you've been talking about that, but I think just to recognize how important several of the people who attended felt that was.
Yes. The physical co-presence is a very pleasurable aspect of doing treatment. It's something that you have to give up. If you do technology-mediated treatment, you give up that sensory pleasure, as does the patient. And not everybody is willing to give that up. Now, you have to acknowledge the loss. That yes, there's loss, there is loss. But if you mourn it, and if you work with what you have, then you can certainly be analytically equally effective. You may not enjoy your day as much. A lot of the analysts, I think there were some comments, weren't there, that people get very fatigued. Did somebody say that?
It's about people getting very fatigued going on online, even from people who have written about technology-mediated therapy or analysis, but finding it a big strain. Maybe you could comment briefly about that.
Yeah, I think they find it fatiguing because it's new and they're learning a lot and they're massively strained already from the COVID anxieties. Secondly, I think until people realize you just relax, they're inclined to scan the screen looking for things, hoping to see better and imagining if only a patient was in the office on the couch, they'd see the whole body, they'd see it better. It's true they would see it better, but it's a different way of looking. You don't look at what you see, you look at what is happening inside you that is being created between you and the patient.
Well,
and that's important to just to relax. And for instance, I'm sitting up because I'm giving a lecture, but with a patient, you can sit right back. And you can look around, and you should.
yeah. It reminds me that Freud's original metaphor about how to receive the communication was to act like you were a radio tuned to the patient's communications. And that applies. It happens to really apply like we're through a radio. But I think you're saying you do have to learn again to relax as you work. Another topic that
receive the transmissions. Yeah.
To receive the transmissions in an unforced way.
Yeah.
Yeah. Another was about fees. Should they be different for teletherapy?
This is so annoying. I think the government thinks they should be different. They think if it's done by technology, you don't have to pay for a clinic, you don't have to pay for an office, you can do it on the cheap. Well, no, because what we charge for is our time. And we're offering a comparable level of care. I believe that profoundly. And no, I would never charge less for.
Except you would, perhaps.
If the patient couldn't pay for it, yes.
If the patient's losing her job.
Yes, exactly.
That was another question about fees, was what about the economic impact on patients as well as on the therapists? That's a different reason for considering
the COVID epidemic, and that we haven't even seen how bad that's going to get.
Right. So there you.
But I've talked to some young therapists, like one of them just lost 6 patients.
Yeah.
You know, because people are out of work.
For that reason, of course, as always, you'd consider the financial implications, but not because of the worth of what you're delivering.
Precisely.
Another question, and I think here was about silence. Is silence different on the telephone or through video than it is in the office?
Yes, I think it is. It's harder to allow the silence to develop because you become anxious that maybe the technology is failing and that's the reason for the silence. Now, if you have video, it does help you to monitor what's going on. If you're on the phone, you don't know, unless you can hear the breathing, whether the person's there or not. And I certainly had an incident early on when I started using the phone where I didn't realize that my headset had gone on to mute. And the patient who was in a silence was just in a silence. But I was trying to help by saying, you know, maybe you've become anxious by what we were saying, or maybe this, or maybe that. And I started to get more and more frantic, making more and more interpretations to understand. Finally, I figured out the headset was muted. And the patient then said, no, I was just being silent. And I thought you were just haranguing me and criticizing me for being silent. And it was just exactly what I grew up with, always being told that I had to speak up and I had to do this, I had to do that. And I mean, it became actually something I felt embarrassed by, became something very, very useful in the analytic exchange.
I think this gets into the technology.
But just to continue, you can feel the silence. You can feel whether it's an angry silence or a fearful silence or an excited silence. You can feel it. Yeah. So
I think just you're talking about your not knowing you were muted, so on, does remind me that there are technological glitches. There are dropped calls what we found is it's amazing how much can be done despite those technical obstacles. Do you want your last couple of slides?
No. Well, yes, okay, yes, I will. Yeah, it's probably easier just to see it. Because basically it's just a list. It says, next one.
This one?
Yeah. After COVID, are people going to return to their offices? Yeah, many will. Many will prefer it. And their teletherapy days will have been a little interlude, like going to camp and coming back home, as Polanyi put it. Others may find that this has been a useful experience for them, and it would give them access to patients who have had to leave their state, or students in other areas who might like to study at their institute. It's good for people who don't have access to psychoanalysis. It lets us make outreach, global outreach. It provides continuity of care and frequency for people who have to travel, or for snowbirds, or people who go into, analysts who go into semi-retirement and operate from 2 locations, let's say. It's excellent for people in Beijing, Mexico City, Los Angeles, anywhere the traffic is horrendous. These people are traveling an hour and a half to get to a 45-minute session and an hour and a half home. That kind of limitation means they may choose once a week therapy rather than 4 times a week analysis, even if they would prefer it. Whereas if they can come to the analyst once in the week and use tele-analysis for the other sessions, that can support a more intensive treatment if that is what they need and desire. It's useful if the analyst or analyst is immobilized, such as by phobia. I know of a case of someone who was treated for 1.5 years in tele-analysis before being able to venture out to the analyst's office, which then led to other outings. In the case of sudden injury, a massive car accident, for instance, person's mind still works, but their body cannot be moved. Women in the antenatal stage of pregnancy who have to lie up for some months because of a high-risk pregnancy, let's say. They can certainly use the support of psychotherapy, only if it's offered remotely. Someone who loses their nanny and can't leave their children to come to their session. Next. There may be ongoing indications for teletherapy. You have to consider the mobility of the workforce. Relocation, the younger generation, they don't go with one company and stay there for 25 years. They're changing their jobs every 2-3 years, moving around. Adolescents leaving for college. This is a big part of the indication for teletherapy, because when they get to college, what they get in the local health center is 10 sessions, which if they've had high quality, whoops, I just disobeyed my own rule. And you see how annoying that is. Yeah, the adolescents going to college, they get a brief treatment that's not what they're used to. And many of them prefer to stay with their original therapist. Generational preferences. Young people are so used to maintaining connectivity online that they may even prefer the convenience of the online therapy. Some people might want a particular analyst who has a particular specialty or a theoretical approach that they can't get locally. That might be a reason for asking for a tele-analysis. And of course, the one we're dealing with now, the shelter-in-place emergency.
Jill, if it's okay with you, I'm going to put up the next slide so people can see your references.
Okay.
And then I'll note to people I won't leave it up that long, but you can pause the recording here in order to write down anything that you're interested in. While maybe Jill, you make just a couple of last comments, I'll remind people this is going to be followed by the lecture from Ralph Fishkin, and then the two other ones on the course of the pandemic in general and what we can expect as mental health implications from Jeff Taxman. Then Lena Ehrlich and I talking about teaching online, followed by some general discussion, all of which is very interesting and very informative, including to us. So I'll turn it back over to you, Jill, without sharing, for any final comments.
Well, I just want to thank the APsaA COVID response team for supporting this course. I'm thrilled that it includes anybody who's interested and that it is free. I think it's a great thing for us to be getting together as a community at this time and bring together all the resources we have and try to just get through it together, because it's hard now. And it's going to get a lot harder. There's going to be a lot more grief and mourning before we get through this. So thank you all for listening.
And Jill, thank you for, I think, a very instructive and very comprehensive introduction to the problem we're all facing. And I think this point of how the beginning of it, in a way, is kind of an exciting period in some ways, and that we're all doing the new things and so on. It's the long haul that really will be the test.
Yeah, and I'll be so looking forward to hearing what people are learning as they do this new teleanalytic work.
Thank you.
Thank you all.
Thank you all for joining us in this way.
Bye-bye.